So we're going to start going over the details on the shoulder muscles. And with the lower extremity, many of you have told me that learning all the muscle origin, insertion, action, innervation is the challenging part. And I agree. And let's just approach it from a lot of different ways to see if we can do it. So one of the things that several people told me was helpful with lower extremity is thinking of the muscles in functional groups. So I sort of reorganized the PowerPoints from how I usually do it. And I divided the shoulder complex and glenohumeral joint muscles into functional groups. And let's just see how it goes. So there are more recordings, but shorter durations. So hopefully that'll help. And I want to review a little of the osteology in the course of reviewing the muscles. So of course we can learn these. Every PT and PTA student since the beginning of time has learned the muscle origins, insertions, actions, and innervations. And hopefully I'll give you a few tips along the way to help you as well. So the learning objectives, of course, for all the muscles is to identify the primary muscles, the prime movers responsible for moving the shoulder complex joints, origins, insertions, actions, innervations, and their anatomical relationships to each other. So we're going to start with the scapulothoracic. And when we talk about the scapulothoracic joint, or the shoulder girdle is another phrase you'll hear, it's considered the combination of the scapula and the clavicle. So we're talking about the scapulothoracic joint, the acromioclavicular joint, and the sternoclavicular joint. And because all of those work together to guide, influence, and assist glenohumeral motion, which is important for a lot of our functional activities. So always in the body, you have to have proximal stability in order to have distal mobility. So our shoulder girdle is really important, and the muscles of the shoulder girdle, for establishing the stability that's going to allow us to, reach up and pick fruit from trees or whatever, whatever we need to do with our upper extremity. So I'm thinking early man when I say reach up and pick fruit from trees. But so the scapulothoracic joint elevators, so if we want to think of it that way, scapular elevators, include the upper trapezius, the levator scapulae, and the rhomboids. They're all responsible for elevating the scapula. They also participate, all three of those participate in joint and force couples, influencing upward and downward rotation, which we will talk about separately. So there's going to be some repetition of muscles talking about them functionally, and repetition is good for learning. So we're going to do that. Good scapulothoracic posture is considered a slightly elevated and retracted position of the scapula. So we want the scapula to be slightly elevated and retracted. And that way the glenohumeral joint is facing slightly upward. So that's going to give us more stability. And we'll talk about how, when you don't have that stability, what the functional consequences are. So the trapezius is a large superficial muscle. It's diamond shaped, or trapezoid shaped, if you want to be specific. That's why it's called the trapezius. It's functionally divided into three parts: the upper, the middle, and the lower. The upper, middle, and lower trapezius all have different lines of pull and therefore different muscle actions. So you can see the upper trapezius has a obliquely vertical line of pull, so vertical and slightly medial lateral. And the middle trapezius has a pretty much medial lateral line of pull, and the lower trapezius has an obliquely vertical, but going in the other direction from the upper trapezius. So look at those fiber directions, and that's going to tell us a lot about what happens when the muscle shortens, because it's the myofibrils, the muscle fibers, that are going to shorten when the sarcomere shortens. And that's giving us our line of pull. So knowing the that we have those divisions of the trapezius is going to help us remember that functionally, I hope. So when we're just going to divide it out into the upper trapezius, remember it's got to elevate the scapula. So part of it's got to be attached to the scapula, right? And then part of it has to be higher so it can elevate the scapula, superior to the scapula. So its origin, its superior or insertion is the external occipital protuberance, which is the knot on the back of your head. So we'll look at that in a minute. And the ligamentum nuchae is, you can think of it as a neck ligament that attaches to the external occipital protuberance. So that's its superior attachment. The insertion is the lateral third of the clavicle and the acromion process. So it attaches right, let's see, do I have a scapula with a clavicle on it? I don't think I do, but oh, on my skeleton, that's who has that. We'll get the skeleton down here to talk to us. So when we look at the skeleton, the upper trapezius is going to insert up here on the external occipital protuberance, and it's going to go down to the acromion process and the outer third of the clavicle. So you can see that line of pull. And I actually did some videos with rubber bands and the muscles on the skeleton for the shoulder muscles, and hopefully you'll find that helpful, because a lot of people said in the first lab they found the rubber band business helpful locating and determining muscle action. So given that line of pull, it does scapular elevation. It's also part of the force coupled for upward rotation, but we'll talk about that later. It's innervated by the spinal accessory nerve, which is cranial nerve 11. So the whole trapezius is innervated by that same nerve. A lot of the scapular muscles are innervated by nerves that are kind of specific to that muscle. So each one kind of has its own little nerve exiting off the brachial plexus. The entire upper extremity is innervated from the brachial plexus, which is a network of nerve roots that come from C5 through T1, basically. C5 and 6 form the upper trunk of the brachial plexus, C7 forms the middle trunk, and C8 and T1 form the lower trunk. They travel a short distance and then they mix together and end up forming the peripheral nerves that go down the upper extremity. So I don't expect you to know a ton about the brachial plexus, and we will talk about it more next year in neuro, and we'll talk about the different plexes and everything. So just now know that the brachial plexus innervates the upper extremity. That's the main thing I want you to know about it, and it comes from the lower cervical and first thoracic nerve roots. Okay. So here's the cranium osteology, which we haven't talked about yet. We'll talk about in a couple weeks. But the external occipital protuberance, like I showed you on the skeleton, is the little knot on the back of your head. It's really easily palpable on most people, even people with a lot of hair. People who don't have a lot of hair, you can even see it sometimes. So it's there, little bump on the back of your head. It's located at the midpoint of the posterior skull, and it serves as an attachment for the ligamentum nuchae and the upper trapezius. So that just tells you something too about the upper trapezius can affect the head as well. So good old scapula, back to the good old scapula. This is an anterior view on the right and a posterior view on the left. So really, when you look on here, the upper trapezius insertion is noted on the clavicle going onto the acromion process there. And so you can see how if you lift up on that, you are going to lift the scapula up. You're going to elevate the scapula. You pull it towards the external occipital protuberance, it's going to go. So it's going to elevate and slightly retract the scapula, which is exactly what we want to have happen, right? So the levator scapula is deep to the upper trapezius. So the upper trapezius is the most superficial muscle on our upper back. The levator scapula is deep to the trapezius, and the sternocleidomastoid, which is in the sort of the front of the neck, if you want to think of it that way. We'll talk more about the SCM later. Its origin is the transverse processes of C1 to C4. And I have a bigger picture of the osteology coming up next. And it's inserts on the vertebral or medial border of the scapula between the superior angle and the root. So the root of the scapula is where the spine of the scapula hits the vertebral border. So here's the superior angle, here's the root, the levator scapula attaches in between those. So you can see how that has a direct line of pull for elevating the scapula. It also participates in force couple for downward rotation. And it's innervated by the dorsal scapular nerve, as are some of the other muscles on the dorsal side of the body that attach to the scapula. So hopefully that'll give you the dorsal scapular nerve and help you to remember that. So the levator scapula, interestingly enough, since it attaches to the transverse processes of C1 through C4. So here's our cervical spine. So the transverse process is out on the corners, basically, of the vertebrae, C1 through C5. If you have a tight levator scapula, that can have consequences on your cervical spine. And actually, some cervicogenic headaches are caused by tight levator scapula. And so sometimes getting some skills to do some nice mobilizations in the cervical spine can help alleviate some of that cervicogenic headache pain. And then also working on some levator scapula stretches. So since the levator scapula elevates the scapula, we need to depress the scapula to stretch it. And probably we're going to move the transverse processes of our cervical spine over to the opposite side too, to get that levator stretch. So when you're thinking about where the muscles go and what they do, also think what position you'd have to get in to stretch them. So the rhomboid, major and minor, they're basically in line with each other. They're deep to the trapezius, and they're inferior to the levator scapula. Their origin is on the ligamentum nuchae, just like the upper trapezius. It's kind of contiguous almost with the lower portion of the upper trapezius. And spinous processes of C7 through T5. So it has that sort of slightly vertical but medial to lateral line of pull. So that gives you a line of pull for elevation because of that slightly vertical slant. It also gives you a line of pull for retraction of the scapulae because of the slightly medial to lateral line of pull. And it's part of the force couple for downward rotation. Just like the levator scapula, it gets the dorsal scapular nerve because it's on the dorsal side of the body and it attaches to the scapula. Good way to remember that. So the scapulothoracic joint elevators, upper trapezius, levator scapula, and rhomboids, are responsible for elevating the scapula. Duh, right? we knew that. But good scapulothoracic posture is slightly retracted and elevated position of the scapula, resulting in the glenoid fossa facing slightly upward. So in this diagram, the string represents the upper trapezius elevating the scapula to get that upward facing glenoid fossa. If the upper trapezius is weak or has some nerve damage, something like that, you could get subluxation of the glenohumeral joint because you don't have that support to elevate and slightly upwardly rotate the scapula. And so the humeral head can slip out of the socket. So you see that a lot. You see that subluxation a lot with people after they've had a stroke. So they don't have the innervation to the elevator muscles that are going to give it the right position, and gravity just takes the arm down. So that is something that we're always looking for when somebody has had a stroke and it's something that we're trying to compensate for. Often it requires external compensatory measures like braces and supports of some sort because the muscle hasn't come back yet. When we have a functional electrical stim bike at the clinic where I work, and when you're using it for upper extremity, there are you actually stim those muscles to get the scapular retraction so the arm can move in the right position. And it's really important that you get that done, so you have good quality movement in your glenohumeral joint and you're not damaging the joint. So weakness or paralysis of the upper trapezius over time can lead to a depressed or downwardly rotated scapula. A chronically depressed clavicle may eventually lead to superior dislocation of the sternoclavicular joint, because if the scapula is depressed, that brings the end of the clavicle down, and it makes the other end of the clavicle, the proximal end, tend upward, and it can lead to superior dislocation of the sternoclavicular joint. However, we know that we have those strong ligaments trying to prevent that, so it's not very common. So it's more common that weakness of the upper trapezius leads to subluxation of the glenohumeral joint. And that's the problem that results more commonly than a superior dislocation of the sternoclavicular joint.